Good evening, respected leaders and members of this great profession, modern medicine. Indian Medical Association, College of General Practitioners of IMA Kerala State Branch. It's extremely happy to welcome you all for this academic meeting, which is happening every Thursday from 8 p.m. to 9 p.m. discussing essentials of every day in medical practice. It is applicable for any doctor of modern medicine in any specialty for that matter. Friends, we are working our best to make sure that you all get the great faculties with the right topic, which is really most useful for each one of you. Still, we humbly request you not to hesitate to write to us saying, these are the topics that we would like to listen. These are the faculties from whom we would like to hear, because in a team, together, everyone achieve more. And IMA CGP truly believe in teamwork. And please do write to us. And also, any good thing, it becomes really useful only when it is shared. Always feel proud to share the news of IMA CGP, particularly the CME series, among your college, school mates, the MBBS mates, hospital groups, IMA branch groups, wherever. Because empowering a general practitioner not only empowers his patients, but also himself. Friends, with a small introduction, let us go to today's program. As you all know, we run a WhatsApp channel by name IMA CGP WhatsApp channel. We'll share the link in the chat group. Please do visit there. You will get very good updates too on every day. Then please note that this webinar series with the title Essentials of Everyday in Modern Medicine will be there on every Thursday at 8 p.m. till first week of November for sure. And towards the end of the year, the season, we'll definitely let you know whether this program is continued or not. Okay, be there. And we have same Zoom ID, same passcode, and same link that you got today for every meeting, every Thursday. Don't search for the Zoom ID, passcode, and all. It is the same. And the program will also be live streamed through the YouTube channel, IMA Kerala Official. And you can log into the YouTube channel to listen to the program again, and never hesitate to ask any doubt at the end of the program. If you have a doubt which you don't want to share in a public platform, please check my name and send chat directly. I'll ask for you. Friends, today we are discussing an extremely common topic, bronchial asthma. But we all think that we know asthma, that I know very well. But I do not hesitate to say that it's like community medicine topic. When you read it, you understand everything. But when it comes to an examination, what is the difference between the goal and there are a lot of words, right? What is exactly goal? What are the sustainable goal, or what are the objectives? There are some technical terms, right, in community medicine. And when we come to write an examination, it becomes difficult. Bronchial asthma, some of us would already been suffering from bronchial asthma and still suffering. And there are umpteen number of patients. And whichever patient you treat, there may be bronchial asthma coming as a comorbidity. Here, there is a great, passionate human being, a clinician par excellence. I should say that a fine gentleman of modern medicine, always standing for the common good, an excellent leader, Professor Dr. Shahjahan PS, talking to us on bronchial asthma, what we really must know. Friends, with immense pride, let me invite Dr. Biju Nelson, our Secretary of IMA CGP, to formally introduce our Professor Dr. Shahjahan. Over to you, Dr. Biju Nelson.
Good evening, Dr. Prashant CV, Director CGP Kerala, Dr. P.S. Shahjahan, our faculty of the day, senior IMA members, dear friends. It is my privilege to introduce today's distinguished speaker, Professor Dr. Shahjahan P.S., Head of Department of Respiratory Medicine, Government Medical College, Kollam. He had his MBBS from Alpi Medical College, later his MD from Trivandrum Medical College, and also DTCD from there. He also had an MPhil in his name in the field of medicine. A widely recognized respiratory expert, he has made significant clinical contribution to the coastal Kerala areas. He is also an expert in the management of asthma management, COPD, tuberculosis, and chest diseases. He was the recipient of the prestigious P.K. Das Best Doctor Award in 2022. Now he is additionally appointed as the Chief Liaison Officer of the Director of Medical Education, Kerala. He has also served as a member of Board of Studies in Medical PG under Kerala University Health Services, Health Sciences. Known for his clinical expertise, academic excellence, engaging teaching style, has inspired many students and physicians through his dedication to respiratory medicine. On behalf of IMA CGP Kerala, it is our pleasure to welcome Professor Dr. P.S. Shahjahan. We look forward to an insightful and enriching session. Ladies and gentlemen, please join me in giving him a warm welcome. Thank you, sir.
Absolutely, whatever Dr. Biju Nelson has said, I think beyond words, one could give a big salute to Professor Dr. P.S. Shahjahan sir, because apart from being a very good doctor, he's always, like Dr. Biju Nelson said, he's always there in the community. And he's also the leader of the Pulmonology Association, and he has led the association with a community support, to which I was fortunate to associate in many occasions. Sir, let us start the program. Over to you, sir. Actually, in fact, our Professor B. Jayaprakash sir and Shahjahan sir is like Mammootty and Mohanlal in pulmonary medicine. True to the core, absolute personalities. You are, they are fond of, community and teaching. Sir.
Is my side visible?
Yes, sir. Very good.
Okay. So, very good evening. First of all, I thank Dr. Prashant and Dr. Biju Nelson and the team, the entire team, for inviting me for this weekly webinar series of IMA CGP Kerala. And thank you, Dr. Prashant and Biju Nelson, for the glorifying words. Many of them think I do not deserve, but still, thank you for the kind words. So, what all things we should know about asthma? That's a very important question and very important issue we should address as a medical community, because asthma is very common. It's one of the very common chronic diseases which we know from antiquity. So we all should, whether you are a general practitioner, a physician, or any other specialty, you should know what is asthma, how I should manage, what is the basic pathology, and at least the basic treatment protocols for asthma. So with this, let me start with the first slide. I have these much disclosures. First of all, I'm not against artificial inhalers, but still, I should say this presentation is not generated by AI. And I have used a few of the GINA, that is a global initiative for asthma. And their slides are their intellectual property and copyrighted. We can use it for educational purposes, but not for commercial purposes. And This presentation will not address the pharmacotherapy of asthma in detail. We will address the general features, general things, in what all things we should know about asthma. That is basically this lecture, not on the detailed pharmacotherapy of various grades of asthma, various types of asthma, phenotypic, endotypic asthma. We do not discuss this time. Okay, with this background, let us start with the first. When I was a PG student, I have seen this advertisement in some of the journals. Uh, that is of a boasting nature. Asthma, so what? Of course, partly it is true. There are many luminaries in the field of science, in the field of uh, arts, in the field of sports. There are many luminaries in the with asthma, and asthma did not serve as an obstacle for their victory, for their life, actually, whatever they were. So, an asthma patient can dance, an asthma patient can swim, or an asthma patient can do whatever he or he likes. So, this is partly true in the sense that asthma, so what? But still, this advertisement is somewhat boasting nature. In reality, in the ground, in the society, this is not true. Let us look at this. This happened in 2009. An asthmatic student dies. Delhi school faces. See, this girl died not in a remote place in India. It is the central capital of India, in New Delhi, in way back in April 2009. She couldn't get the proper medication, and she had asthmatic attacks during while she was in school, and she could not get the proper treatment, and she died. We could have saved that child. Don't think that this is an issue of India alone. See, there is a Western, this is Western, it's in Minnesota. What happened in 2024? What happens is that the the child died because the treatment was delayed by the parents, not in India, but in Minnesota. So there was a case against the parents. Why? Because of the delay in treatment. So this happens everywhere. That means asthma is still a major problem. Even though we have n number of medications, we have state-of-the-art facility to diagnose or treat asthma, but still there are so many deaths happening, preventable deaths. The deaths are happening due to asthma. So with this, see, what are the treatments available? We know that we have lot of most modern techniques available, targeted drug delivery for asthma. See, fish therapy for asthma. Actually, this slide I was hired from none other than Professor Dr. B. Jayaprakash, my colleague, friend, and mentor. So this still happens. Some decades back, it was a very, very famous festival at that point of time during the in Hyderabad, fish therapy for asthma. And the volunteers are not illiterate people, people from IIT, engineering colleges, etc., etc. The volunteers to give medication, that they are putting a small amount of drug, which is in a small fish. They are asked to swallow the fish. So they see there are so many volunteers too. They are highly educated. So fish therapy for asthma is still there in India. Okay. So let us look into the advertisement again. Asthma, so what? Is it so? Then in reality, the answer is a very big no. So there is a wide gap exists between treatment options available and its effective utilization. This is not only in India, it is a global phenomenon. Naturally, it may be more in India because of the issues we all know. But there's no doubt the correct medications in the correct way very small percentage of the asthmatic patients receive, and still there is a wide gap exists between the treatment options available. Okay, let us look into the burden of asthma. What is the burden of asthma? When you talk about the burden of diseases, respiratory diseases cause significant burden, especially in India and countries like India, the developing countries. Okay, so asthma is one of the most common chronic diseases worldwide, irrespective of the country. A rough estimate says that 300 million suffer from asthma globally, and prevalence is increasing all over the world, especially in children. And it is estimated that in the last year, around 200 million new cases in the last year, 2025. And coming to the Indian statistics, more than 35 million in India, and any health index estimates in India are gross underestimate, and this is true for asthma too. But the official uh, estimate says that India, more than 35 million in India people suffer from asthma. Naturally, asthma is a major cause of school and work absence. Healthcare expenditure on asthma is very, very high, and it is again increasing. And there are 4.5 lakhs death annually due to asthma globally. See, when you speak about the asthma mortality, we can say that most of the asthmatic death, more than 90% of the asthmatic deaths can be preventable. So that means around 4 lakhs preventable deaths are occurring due to asthma globally. And unfortunately, we account for 42% of the death toll. That means nearly 50%. That is, we 42% of the death toll are contributed by India. So this is the burden of asthma as a whole. So what is the asthma paradox? See, we have very effective medications available for asthma. We can have a near normal function with asthma if you are taking the medications properly. And there are beautiful guidelines. There are global initiative for asthma guidelines from Europe, Canadian guidelines, Japanese guidelines. We have a guideline. So very beautiful guidelines are there, and very effective medications are available. But still, asthma exacerbations are on the rise. Asthma exacerbation is increasing, and naturally, asthma death is increasing. So, this is the asthma paradox. Despite effective medications and guidelines available, the asthma exacerbations and asthma death are increasing. That is what is the paradox we are facing. Okay, see, the problem is that asthma is poorly managed. Asthma is poorly managed everywhere. Lack of awareness by people suffering from asthma and the society at large is the major problem. Misconceptions about inhaler therapy is another issue. Steroid phobia is a very big issue. And equally important is that, especially country like India, the cough therapy is very, very major problem. So look at, there is underdiagnosis, under treatment, and equally wrong treatment as well. So if you look at the use of inhaled medicines, only around 9%, that is around 10% of the people are using inhaled medication in India. Maybe in Kerala, it may be a different statics, maybe more percentage may be taking. But still, if you say as a whole in India, only 9% of the people are taking inhaled medicines for asthma. There are so many issues. We will come to that. So, filling the knowledge gap is very, very important. Education matters, education empowers. Education to the society, education to the patient, and not only the education to the patients and society, educating our healthcare team. I have seen that many of our doctors, very respected doctors of different specialties, oh, can we wait for some time to start inhaler? That is so. Instead of waiting for inhaler, you have to start with inhalers, and if the things are not controlled with inhalers, we should give oral medications, parenteral medication, etc., etc. That should be the way. But many people want inhalers at the end. So education matters, education empowers. So let people, patients know about asthma. Many of our patients do not know they have asthma. They name it another thing, a cough, etc., or some bronchitis, etc. They do not want to name as asthma. So asthma is a chronic lung disease that affects people of all ages and race. To be frank, it can occur at any point of time, at any age, though it starts usually in childhood. It is caused by inflammation of the lining of the airway. Asthma means inflammation. This inflammation causes the airway to narrow. Because of the inflammation, the airway getting narrowed and make it difficult. Naturally, secondary to the inflammation, the lungs produces excessive mucus, which causes further narrowing the airways. Okay, so let us look at there are risk factors for the development of asthma. There are triggering factors for asthma, and the airway hyperresponsiveness is there that is causing inflammation. This inflammation is causing airway obstruction, and significant airway obstruction causes classical symptoms of asthma. So asthma, there is airway inflammation and there is bronchospasm, not in the reverse. Bronchospasm is not causing asthma, but airway inflammation is there in causing bronchospasm. That is what is causing the symptoms. See, the first one is the normal bronchiole. We can see the airway lumen beautifully. The second one is the asthmatic bronchiole. You can see at various points it is constricted due to inflammation, and you cannot see the lumen properly. This is the model which shows the normal bronchiole and an asthmatic bronchiole. So let us know what is asthma. Asthma affects, we have already discussed, asthma affects all ages and race. No age is immune, no race is immune. It is not contagious. Some people believe that it is contagious, especially if you develop, so your relative develop asthma, you may think that it is religious, especially for couple. If the husband develop asthma or asthmatic symptoms, he may think that it is contagious from his wife. So these things are still there. It is not contagious. Asthma is not a single disease. That is one of the most important things we should know. Asthma differs from person to person. Different phenotypic variants of asthma is there. You can call it as a spectrum of disease, spectrum of airway disease. Asthma differs from person to person. People with asthma can and should exercise. They should exercise. They should do their routines. They are not supposed to take rest always. They should exercise. It is not a psychological disease. Many people still believe that it is a psychological disease. It is not a psychological disease. Though stress is an important trigger in the development of progression of asthma, it is not a psychological disease. It is not a condition to be ignored, serious enough to endanger life. Many people believe that, oh, you can take some medication, many doctors, for sometimes, even if you prescribe inhalers, they can take it for 1 week or 2 weeks. When the patient is okay, they can relieve of inhalers too. No, it is serious enough to endanger life. We have already discussed around 4.5 lakhs people die of asthma globally. It cannot be cured, but it can be controlled well. See, many of the diseases, whether it is diabetes, whether it is hypertension, we cannot cure, but we can control. Similarly, in asthma too, we cannot cure in the pure sense, but we can very well control asthma. Remember, asthma is one of the diseases which respond to medications very well. Even if the patient is in a very bad shape coming to your casualty, within minutes, if you give nebulization, you give parenteral medications, you give medications, etc., etc. And within minutes, patient respond very well and he or she become normal. That is what asthma. So asthma respond well to medication. One slide about asthma in children. It has been estimated that asthma will disappear in 30 to 50% of the children at puberty, but often reappears in adult life. This disappearance is not equivalent to cure. Please understand, this is not equivalent to cure. It may disappear for some time, but it may appear. Okay. So childhood asthma is more prevalent in boys than in girls. More females than males develop asthma during puberty and continues as such. And up to two-thirds of children with asthma continue to suffer through puberty and adulthood. Childhood asthma must never be ignored in hopes of the child outgoing it. As we told earlier, 30 to 50% of the children at their disappearance symptoms in as high as 50% of the people. That is what is called remission. This kind of remission can occur in a significant percentage of children, especially in males. The studies have shown that it's more common in males. Okay, whatever it may be. But remember, don't think that the child will outgrow asthma and there is no need for treatment for milder, especially for milder symptoms. If the child is very sick, we all take the child to the hospital and get treatment. But for mild wheezing, many a time they do not seek, many people do not seek treatment, considering that he may or she may outgrow asthma. That is unfair, and the inflammation can lead to many a problem in the future. So coming to the triggers, what makes asthma worse? Allergens, irritants, physical condition. Many things can cause asthma worse. And what are the common allergens? Warm-blooded pet dander, dogs, cats, birds, and small rodents. House-dust mites, very, very important. Cockroaches, very, very important. Pollens from grass and trees, molds, etc. are the common allergens we know. And there are so many irritants: cigarette smoke, wood dust, scented products such as hairspray, cosmetics, cleaning products such as glass cleaners, bathroom cleaners, laundry detergents, strong odors from fresh paint or cooking, very, very important. Recently painted houses, rich in irritants. Automobile fumes and air pollution, a growing problem. Chemicals such as pesticides and lawn treatments. All these can exacerbate the already established asthma, or it may cause a reactive airway dysfunction and may lead on to asthma in a very some percentage of cases. So irritants are very, very important. Physical conditions like infections in the airways, such as colds, especially viral infections, are very common trigger factor, serve as very common trigger factor for asthma. Exercise induce asthma. Strong expression of feelings, crying or laughing, that is emotional outbursts, can precipitate asthma. Change in weather and temperature, cold air, humid air, the climatic changes, global warming, all can lead on to asthma. Gastroesophageal reflux disease, a very important trigger for asthma. Then another type is that catamenial asthma, that is during menstruation, people may experience asthma. That is what is called catamenial asthma. And pregnancy also a precipitant factor, serve as a precipitant factor for asthma in some patients. Okay. So what are the factors influencing the development and expression of asthma? We can divide it into two: host factors, which are unmodifiable. It can be genetic, genes predisposing to atopy, genes predisposing to airway hyperresponsiveness, obesity, gender, etc., etc. The host factors. And environmental factors like that are largely modifiable. Allergens, indoor, we have already discussed. Outdoor allergens, infections, occupational sensitizations, tobacco smoke, indoor and outdoor air pollution, some diet, etc., etc., can serve as a precipitant factor for asthma. But these are largely modifiable, or the host factors are largely non-modifiable. This is one of the interesting slides. Is stress an important trigger for asthma? The UK asthma study shows that as high as 43% of people with asthma says stress an important trigger. In adults, it is 45, and children it is 30. So in adults, the stress factor is very high. In children, around 30%, 29.1% says stress is an important factor. There are so many other factors as well. Coming to the what are the treatment options? Before treatment options to discuss, we all know that inhalers are the best, but there are concerns and controversies. These are known to all of us actually. Inhaled medications are addictive, someone says. They should be used only in emergencies and serious stages of the disease, should not be given to young children. They have to be used lifelong. Another false belief. Once started, they cannot be stopped. And many believe that, question that, are they without any side effects? And some persons believe that the powder used in dry powder inhalers can block the bronchial tree. That is another concern. These are the only few concerns which I noticed. There are so many concerns are with the concerns. We have to address. Unless you address, they won't use these medications properly. So why there is inhalation? Why? Actually, this inhalation therapy, the terminology is a misnomer. Actually, we should call it as a targeted drug delivery. That means we are giving the drug where the disease is. In oral, the onset of action is slow. We have to use large dose because we have to give the medication to all cells. A greater side effect because we are using larger dose and usually not useful in acute symptoms. Oral medications. But when you use inhaled medication, rapid onset of action, because you are giving only to the bronchial tree, less amount of drug is needed, better tolerated, and treatment of choice in acute symptoms. Next issue is that, are they wonder drugs? People will ask you, doctor, is it a wonder drug or like that? Can I use it like that? Many questions. Inhaled drugs are not wonder drugs or newer drugs. Most often they are drugs used for systemic use in minute quantities. At times they are with some modification in chemical structure. Less frequently, they are available only in inhaled form due to poor gastrointestinal absorption. So they are not wonder drugs. They are drugs available for use. That's only. So we are giving it to the bronchial tree only. That is why patients are getting benefited. They are not new drugs. They are not wonder drugs. When you are giving inhalers, the technique is important. When you are giving a tablet, just swallow it. Of course, sometimes you may have to take it after food or before food like that, but still just take it, swallow it. Injections also, intramuscular, intravenous, or water, just inject. That's but here the inhaler track technique is very crucial. Educate about the correct inhaler technique and reassess it periodically. Very important. And when you are taking inhaler devices, take patient preference into account. If no compelling reason to pick the physician's choice, sometimes we may have to have a specific choice due to many a reason. In such cases, you can use the device which you want. But otherwise, generally in asthma, ask the patient which device you want, because if the patient likes it, they will use it regularly. Otherwise, they will not use it and they will not be benefited. And invest the time to train each patient in proper inhalation technique. Recheck the inhalation technique on each visit. That is very important. Either the doctor or his assistant should recheck the inhaler technique on every visit. That is very important. And you have to address the adherence and non-adherence. Adherence to inhaler and proper inhalation technique are the key to have a best result for asthma, not only for asthma, any respiratory disease in which inhalers are being used. So non-adherence to asthma therapy, particularly to inhaled steroids, is a common problem contributing to poor asthma control. Non-adherence is often a hidden problem. It can be unintentional or intentional. We'll come to that. What do you mean by unintentional? Because the patient do not have any money. Patient do not able to buy it because they are living in a remote area, not in Kerala. In some other places, remote areas are there. Their medications are not available. So it can be unintentional. So on the other side, it can be intentional too. See, they believe that this is addictive, this is highly toxic to their system. So it is, and sometimes that is we already discussed. So in such cases, the non-adherence is intentional. And another part is that it may be pseudo adherence too. It is not always due to negligence, maybe not due to tail off effect. What do you mean by tail off effect? See, we have seen that in MDs with this MDs, you can see that 120 puff, 120 actuations or 150 actuations. So even if you puff, even after 120 or even after 150, the inhaler it can propel due to the propellant affection. So beyond the labeled number of actuations, propellant can release an aerosol plume that contains little or no drug, a phenomenon called tail off. This is overcome by, you can use nowadays dose counters are there. So it is largely this can be addressed, and drug delivery per actuation may be very, very inconsistent and unpredictable after the labeled number of actuations are there. So that means after 120 or 150, what they said, after that, you are getting only the solution, only the propellant, not the medication. So the patient may not benefit. But now we have other methods like dose counters are there. Many, many methods, electronic devices are there. So you can utilize the service and you can take you can avoid the tail off effect. This is the inhaler, the data on our study. We conducted a study earlier, and it was some 2006, around some 18, 20 years back. So the beliefs can be might have changed, but this was the result at that point of time. 48% are reluctant to take inhalers. 47 believe that term inhaler is the name of a particular drug rather than a device. They believe that the inhaler means the name of a drug. They do not know there are many drugs available in the form of inhalers. 76% of the inhaler users do not know how to use it properly, and 7% of the inhaler users think the powder in the dry powder inhalers can block the airways. So this was the results of our study some 18 years back. So let us look some myths and misconceptions of asthma. None of my relatives have asthma, then how? That is one of the questions many people ask. We can very well tell them that, see, you know your father, you know your grandfather. You may not know your great grandfather or the generation beyond that. So we do not know whether asthma in the present or not. So it can. So the genetic disease does not necessarily mean that it occur in your father, mother, or your children. So it can skip generations. So another thing is that even without any family history, anyone can develop asthma. So even without your relatives have asthma can develop. Many people relate eosinophilia with asthma, and they say that I have no eosinophilia, so I have no asthma, or they said I have only eosinophilia, not asthma. So asthma in asthma is in asthma, eosinophilia can occur and cannot occur. So you don't equate eosinophilia with asthma. Is food, this is another question, is food avoidance restriction needed in asthma? If someone is allergic to a particular food, avoid that. Otherwise, no need to avoid that. Can steroid be given to children? See, steroid is a life-saving drug. If it is needed, it has to be given even for the newborn. That is the we already talk about the magical remedies, single shot drugs for asthma. Absolute nonsense. Is asthma contagious? No. But at the same time, asthma can occur in a shared environmental trigger. Suppose you are living in a house together, the environmental issues, the dust, the fumes, etc., you are sharing the same room. All these things can cause asthma. It is not contagious, but because of the environmental sharing, asthma may occur in husband, wife, relatives, etc., etc., even though it is not contagious. Will asthma exacerbate during full moon, new moon, etc.? There is a strong belief among people, but we do not know. At present, there is no evidence to say that asthma exacerbates during full moon or new moon. But many people believe that there is. It could be due to the episodic nature of these symptoms. Actually, it could be probably they are relating the episodic nature to full moon and new moon rather than the actual causation. Is continuous therapy is insufficient to treat during symptoms? See, I already discussed asthma means inflammation. We have to address inflammation. We have to treat the patient continuously for some time. There is no scientific data that is unwise to treat during symptoms only. We are not treating the symptoms. We are treating the underlying inflammation. Can I marry a normal sex? Say a controlled asthma means your life is nowhere any no hurdles. You can do whatever you want. You can have a normal life. Will controlling rhinitis it will possible? This is a common belief in Alappuzha and Central Travancore. Controlling rhinitis will precipitate. It is on the reverse. You have to treat the allergic rhinitis but correctly, because the combination of asthma plus allergic rhinitis is the deadly one. If you find it difficult to control asthma, you find it difficult to control allergic rhinitis. Both are there. So you have to treat allergic rhinitis properly to control asthma. Will it disappear naturally? See, there is remission is described in asthma. Many patients have remission for sometimes, but it will not completely cure. It will not disappear. It will disappear for some time. Are inhalers and addicting and dangerous? Obviously, no. Inhalers are a medication just like any other medication, like antihypertensives or the anti-diabetics. You have to take it regularly, but that does not mean that it is addicting or dangerous. There are so many myths and conceptions are there. I have quoted few of the misconceptions what I heard from my patients. Okay. Coming to the management part, the most important part is avoiding triggers, not pharmacotherapy, avoiding triggers. Animals outside or inside the homes, dust mites, carpets in our bedrooms, bedspreads, pollens, and mosquito coils, incense sticks, air factories. These are to be avoided. Avoiding triggers, this particularly this dust mite is very common. We cannot see with our uh, eyes, very small with the electron. This is the electron microscopic picture of a house dust mite. It's one of the most important precipitant for asthma. So any dust, any fume, or any irritant, we already discussed, is detrimental for the control of asthma. So we have to avoid these triggers. Asthma is not a just one disease. It is an umbrella term for so many phenotypes, so many endotypes. So we have to address it with the equal importance. And one size not fit for all. That's very, very important. So coming to the personalized asthma management based on symptoms, exacerbations, side of lung functions, you have to sometimes you may have to take the biomarkers and you have to plan treatment. And you may have to confirm the diagnosis if necessary. Symptom control and modified risk factors we already discussed. We have to address the comorbidities, if any, and most important, we have to have the inhaler techniques and adherence. And while prescribing inhaler device, you have to take the preferences of the patient as well. And treatment of modifiable risk factors and comorbidities is very, very important. Non-pharmacological strategies, including pulmonary rehabilitation, is very important. And when you ask me which is the most important drug or what is the mainstay of treatment of asthma, it is inhaled corticosteroid, none other than inhaled corticosteroid. So, and we have to teach the patient on how education, asthma educations, how to train with, and we have to have a asthma action plan too. But even with the many, we already discussed, even with this kind of medication, inhaled medication, people do not respond. So in such cases, we have to address why. First and foremost, point towards you, it could be a wrong diagnosis. we have to exclude other causes. You may not be dealing with asthma at all. You exclude other causes. Second, it could be due to an avoidable factors, like you have to control the environment. Third, it could be a inappropriate device you are using. So we have to address the which inhaler device the patient likes or not. And non-adherence is an important factor. You have to use diaries, education, dose counter devices, etc. Nowadays available. Then it could be a wrong dose or medicine. You may not be giving the correct medication, or you may be giving a microscopic dose. People many a time people used to say, "So this is a big dose, big dose." There is no big dose or small dose. There is only adequate dose. So you have to give the adequate dose for the patient. So, for example, I will tell you, in children, for example, in any most of the medication in children, we give 1/4 or 1/9 of the adult dose, whether it is antibiotic, whether it is NSAIDs, or whatever it may be. But when you think about the inhalers, the dose is same for the similar grades of severity of asthma in a 3-year-old child or a 30-year-old person or a 60-year person, same dose. Because in children, their airway caliber, the trachea, everything is small. So the drug reaching to the airways are less. So we have to give equal dose, more or less equal dose as adults. So the wrong dose is a major issue. Then concomitant medication, many of the medications, NSAIDs, AC inhibitors you are using may interfere with asthma control. In such cases, you will have to use safer ones. There can be exacerbating conditions like reflux esophagitis, sinusitis, rhinitis, etc. Such cases has to be treated properly for the proper control of asthma. And lastly, see, over a period of time, not only asthma, any condition can deteriorate. So adopt preventive strategies. So these are the poor response to inhaled medication. Why there is poor response to inhaled medications? Then a word about the biologics. Any talk on asthma is not full or not complete without saying something about biologics. These are the recent advance in asthma medications. They are strictly considered as. But remember, we have romalisumab, mepolizumab, benralizumab. So many drugs are available. High cost drugs are available. But remember, they are strictly considered as add-on treatments rather than standalone treatment options. In the setting of a periphery, the role of biologics in the asthma management is very limited, practically zero. So uncontrolled symptoms, despite consistent use of high-dose inhaled corticosteroids, combined with the long-acting beta-agonists, we may think of biologics. Frequent asthma flare-ups, recurring multiple emergency room visits, or rescue courses of systemic oral steroids like prednisolone. Because in an asthmatic patient, if you are forced to give systemic steroids, very often think of using biologics. But before using biologics, you have to identify biomarkers confirmed through specific tests by experts, like specific IgE, elevated absolute eosinophil counts, or fractional exhaled nitric oxide. So before concluding, I should say, if you ask me what is the treatment of choice for asthma, it is none other than inhaled corticosteroids with or without long-acting beta-agonist. In most of our asthmatics, we need to have a combination therapy of inhaled corticosteroids and long-acting beta-agonists. And remember, asthma does not mean that it classically present with this wheezing, cough, etc. Many times, patient present with the cough. Many patients cough. In the older times, we used to call it as cough variant asthma, especially in children. The only symptom is cough. So there can be cough variant asthma. Many phenotypes of various are there. So it's a nocturnal asthma. Some people may have problem during night only. Some people are having during exercise only. Some people are during menstruation period only. Some people have during pregnancy only. So there can be so many phenotypic variants. So whatever may be the phenotype, the major stay or the standard treatment or the mainstay of treatment of asthma is inhaled corticosteroids plus long-acting beta agonists. We have so many inhaled corticosteroids available. We have so many long-acting beta agonists available. We can have beautiful combination of different drugs like formoterol, budesonide. You got smart therapy, single maintenance and control therapy. Smart therapy is there. So it is up to the clinician as well as the patient to discuss and plan treatment. But remember, there is no role for short-acting beta agonist alone for asthma. For our classically speaking, our salbutamol alone has no role during the maintenance of control of asthma. You have to use inhaled corticosteroids plus long-acting beta. And to conclude, asthma is a major public health problem worldwide. It is primarily a more reversible airway inflammation starting usually in childhood. Introduction of inhaled corticosteroid medication, especially corticosteroids, revolutionized the management of asthma. Inhaled route deliver drugs to the site where it is needed. Constraints and fears on the use of inhaled drugs should be addressed properly. Selection of devices are important in treatment and patient compliance. The patient should be trained and retrained periodically for the proper inhalation technique. Currently, as of now, inhaled route is the most effective and safest modality to treat obstructive airway diseases. And these are the resources. If someone likes to discuss or read more about asthma or to detail the sophisticated protocols, you have so many good data is available. See, if you look at the site and GINA strategy report 2026, GINA slide sets 2026 is available. GINA 2026 summary guide is available, and the severe asthma short guide is available. GINA podcast 2026 is available. It is free for personal use. We cannot use it for commercial uses, but it is free of course for our education purposes. Thank you.
Shajan sir,
Yes.
there is no word, because simplifying bronchial asthma, but yet including all essential facts and matters for which will be useful for every doctor of modern medicine. You have done it in a grand way. Thank you all. Thank you, sir. I am sure all the audience will join me in that. There are a few questions. We'll quickly address the questions. Sir, first of all, let us say now it is the era of cockroaches. Now let us start from cockroach. Well, there may not be any house without cockroach. And actually, what is the factor of cockroach, which has relation with the bronchial asthma?
The excreta is the problem. Excreta contain lot of allergens. See, one allergen may not be problematic for one asthmatic. It may be about some other asthma. I already said it varies from person to person. The cockroach excreta is full of allergens, and generally it is one of the most important allergen what we find in our setting, especially in Kerala setting, the warm, humid atmosphere. Cockroach excreta contains a lot of allergens.
So wherever there is a cockroach, there is a management strategy for cockroach as well. Someone jumping with a spray. Well, how do you see that? Will it be posing more problem than?
I didn't get you, Prashant, actually.
Sir, whenever there is a problem of cockroach in a house, there comes something number of solutions, which includes a lady jumping with a spray.
Actually, the food don't keep the food waste in your dining table. Keep your bedroom clean, hygienic, etc., etc. is the answer. But you know that is very, very difficult for you also, for me too. So what we can do is that see, once in a while you can use this kind of cockroach remedial measures, but don't be there. If suppose you are going for a vacation to some place, some 2 to 3 days, you are not in your house, you can put some anti-cockroach measures and you go. Don't be there because that will cause that is an irritant and that will cause problem. So that can also you can do.
Thank you, sir. Thank you. Now, there is a concern raised by one of the senior doctor. That is some nephrology people. He heard some nephrologists saying that the topical and inhaler steroids can lead to renal injury. How far it is right? Kidney injury.
See, there is no evidence to say that. See, I will tell you, inhalers are small amounts of other drugs too. So if you are not using inhalers, you have to use the large quantities of either tablets or injections. That will naturally to reach your kidneys very fast. Inhalers also got some systemic absorption if you are using it in large amounts. For example, suppose you ask the patient to take one puff in the morning and one puff in the evening. If the patient is taking it 10 puff or in the morning, 2 puffs by 11 o'clock, 3 puff by 3 o'clock, like that, there is some systemic absorption. So steroid can absorb in the body and other issues can occur. But otherwise, inhalers are generally safe because it won't reach the other systems in a significant manner.
Sir, thank you. Thank you
But
very much.
that is what I said. At present, as of now, inhaled route is the most effective and safe at this point of time.
Now, the body spray can, use of body spray by family members can cause or precipitate bronchial asthma in others in their family.
Absolutely. The body spray is an irritant. See, that again, that may not cause problem for every. For example, I am an asthmatic under remission. I had asthma during my childhood. So when a patient come to me with the body spray and the scented people, it's a difficulty for me. I feel suffocated actually. So it may not happen in any person, all person. It may have irritants can cause or can precipitate in some person. The particular irritant may not cause problem in one person, but some other some other irritant can cause problem in other person.
Sir, there is a tricky question which is in another subset, later subset. That is a regular use of lathery perfumed soap. Taking a big bath, will it precipitate bronchial asthma?
If it precipitate bronchial asthma in that particular person, they avoid it. That's the only answer I can say. That otherwise,
I just
see,
asked
you
it.
can use suppose one particular soap is causing not only asthma, you can have contact dermatitis, etc., etc., causing, you avoid that. For example, I will tell you, some people are allergic to beef, some people are allergic to prawn, some people are allergic to wheat. That does not mean that all other asthmatic avoid these kind of foods. There is no general rule. Suppose that particular soap with scented soap is causing problem for a person, avoid that soap. That's all.
And various dermatologists are also of the opinion that we must avoid using, scented perfumed soaps for the health of our skin. Okay, just update.
Yes.
And regarding the inhaler use, is it necessary to use the inhalers during the symptom-free period?
Absolutely. I will tell you why. For example, I don't have any. See, look at this. Believe that this is the caliber of your airways. See, your lung has got so much reserve. So even if because of inflammation, your caliber decreases, maybe up to 50-60%, there won't be any symptoms. Okay. So if there is a 20% reduction in the caliber, no symptoms, but still there is inflammation, still there is problem, we have to address. Otherwise, patient may develop a life-threatening symptoms, life-threatening problem at a later time. Even the mild asthmatic, the so-called mild asthma, it can turn into a very, in older times we call it as brittle asthma. Life-threatening asthma, patient is reaching ICUs, etc., possible. So, of course, you can stop considering your symptoms, physical examinations, spirometry, etc., together. But you cannot simply stop because you don't have symptoms.
Sir, asthma. In pediatrics, are there nebulizers overused in childhood asthma?
with the due respect, I should say there is a lot nowadays. People are using nebulizers so much without much scientific evidence. Nebulizers are needed in some extent, not in asthma, basically in COPD. Suppose a bedridden person, a person, nobody to look after. So, or some caregivers are there. So sometimes the patient have to take in nebulizers. That's true. But in asthma too, also see, the problem with asthma is that childhood asthma. You are speaking about children. You are the parents. They are giving nebulizers, and the child is getting improved. They think that the child is okay, so they are not going. Avoiding physician visit or healthcare facility visit. Sometimes what happens? They continue to give nebulize. The child is getting bad and bad. The child is getting cyanosis. Even deaths have been reported with that. You have to give the oxygen channel too. Suppose there is oxygen simultaneously, if you are not giving oxygen, sometimes the child get hypoxic. So what I used to tell, for example, what I used to as a remedial measure is that you give 30 seconds, you remove the mask for some time, you give again 30 seconds, you mask it. See, that's the only way out. Otherwise, the people, the child can asphyxiated, child can get cyanosis, and that's have been reported. I already told you, that's have been reported from various centers. So there is an overuse of nebulizers, and MDA with the spacer is as equal as nebulizer, no doubt about that. Only thing is that, well, because of this power is using, some sound is there, you may think that it is good. Not like that. MDA with the spacer is equally good.
Sir, when we discuss nebulizers,
Dr. Prashant,
yes, please, Sachi sir.
May I add something more?
Please. Renowned pediatrician from Alappuzha, IMA leader, Sachi sir.
Okay, sir.
First of all, thank you, Shahjan sir, for your excellent presentation and your comment on home nebulizers. I have asked that question because as a pediatrician, I have seen that home nebulizers have become one of the most misused medical devices in children.
Absolutely, sir.
Absolutely. Unfortunately, many of the pediatricians are also prescribing home nebulizers instead of an MDA with a spacer. And nowadays, apart from that, nowadays nebulizer is used for every respiratory complaint at home for children. They use it for blocked nose, for headache, for noisy breathing, common cold, cough, and even for fever. And also, they even add substances like Vicks, menthol, eucalyptus oil, and all other home remedies into the nebulizer chamber. And I have also seen nebulizers being given as a birthday gift. And once they reach a family, all family members starts using it by taking turns. And it has also been passed from one generation to another for use. And as Sir has said, all should remember that an MDA with spacer is a preferred method of delivering an asthma medication for most of the children at home. That is the present GINA guidelines. The present GINA guidelines have stressed the use of MDA with a spacer only. As Sir has again emphasized again and again, an inhaled corticosteroid with an MDA with a spacer is a gold standard in the treatment of asthma. As far as children are concerned, a home nebulizer can be used, as Sir has said, in bedridden patients and for children with acute severe attacks of asthma at home, despite the use of maximum dose of inhalers. And as Sir has said, I have also seen children getting oxygen perfusion mismatch because of continuous nebulizer home use. Thank you, sir. Thank you very much.
Another issue within nebulizer is that the infections are, the channels get infected, especially in hospitals. If you are sharing these channels, that a lot of infections, pneumonia, etc. can occur. So ideally, in my opinion, Indian Medical Association, APA, Pediatric Society of India, and other organizations should come forward to educate the people regarding the misuse of nebulizers. Especially in COPD, every COPD patient is with a nebulizer in our setting.
In the same slot, as you said, 30 to 50% of childhood asthmatics get remission, but may reappear in adulthood. At what age or are they usually likely to get another attack in adulthood?
See, the remission is known to occur in asthma. Many child, that is why people used to say that in child he has asthma during childhood, now it is changed. So asthma in childhood is curable, many people say. This is because of this remission, because the doctor is changing. You are seeing the pediatrician is changing to a physician after some time, actually. So usually by puberty, many of these asthmatics got remission. And it may reappear by 30, 40, or 50. We do not know at what point of time. That is what is called as high as 30 to 50% people have asthma. See, that is why in childhood, around 15, 10 to 15 percentage of people have asthma. In adult, around it is only 7 to 8%.
Sir, just going back to nebulization, there are two more questions on nebulization.
Yeah.
One is, nebulizing at home without oxygen becoming more irritant to the airway tract. Is it right?
Not like that. Asthma is, see, oxygen.
No,
The problem is that the problem with the that is problem with the asthma, and also in children. See, their airway caliber is too small, and during asthma attack, their airway caliber is further small. So you are continuously giving nebulization without oxygen. The mask is on the face of the child, and he or she is not getting oxygen at all. So by some time, the child get hypoxic. So the oxygen channel should be there. If the oxygen channel is not there, you give 30 seconds, remove for 10 seconds, then again 30 seconds, remove it. That should be the alternative way.
Sir,
Even though we cannot.
Thank you, sir. Thank you. Sir, that is a very valid point. Then another thing is that in many of the hospitals, usually that nebulizing channel in the practice setting and all, I have seen many. Previously the nebulizing channel get connected to the oxygen tubing. Now the easy way is a patient is getting oxygen. They just insert the mobile nebulizer and they insert the nebulizer part to the oxygen mask. And very crude method I have
Yes,
seen.
very
And
good. But
it
because
is being practiced.
we cannot say how much medication is getting into the air tract. See, these are all
Things, absurd things, right, sir? I've seen big hospitals and small hospitals practicing this, and probably this is a very important message from today's session.
These are all shortcuts. These are all shortcuts which we can't accept. There is no scientific basis of this.
Absolutely, sir. Sir, during acute attacks of asthma, how often one can use inhalers in one day?
See, if you are talking about acute severe asthma, we have to assess the patient in detail, and we have to give nebulization. Then or MD with a spacer. But for more practical in a hospital setting is not about it is nebulization. So for every 20 minutes, you can repeat. You can repeat short-acting beta-agonist, and you have to consider giving systemic steroids. Systemic steroids are indicated in acute severe asthma. Injections. We often give injections like methyl sandines, etc., etc. None of the guidelines accept the use of or advise the use of these methyl sandines. But in India, a large number of people are using, even now, people are using it regularly.
Thank you, sir. Now, there is another question. What is the significance of absolute eosinophil count and serum IgE levels testing in managing asthma? What is the correct oral prednisolone dose, frequency, and duration in managing acute exacerbation?
So that's a big question, actually. See, the eosinophil count, we often rely for considering biologics and other. Of course, you have to do as a routine eosinophilic count, everything you have to do. IG usually not indicated. If it's say child is coming or a person is coming to you with asthma, you are diagnosing it asthma based on symptoms and based on spirometry, and you are giving inhaled corticosteroid with long-acting methodism, and the person is well controlled as per guidelines, as per goals. There is no need for giving IG because IG is likely to be high. If the person is not improving, you consider that, and you consider anti-IgE treatment depending upon the case. I'm not saying that for every increase in IgE you have to give omalizumab, but in a small percentage of people who is not controlled with this kind of, you can put on IgE, omalizumab, which is anti-IgE. And
Please.
next is you asked eosinophil count also. Eosinophil also as a routine you are doing a CBC as a part, you can do that, but don't just by monitoring the eosinophil count you cannot treat the patient. And if the patient is not improving as per guideline, if you are giving treatment as per guideline, the highest dose possible you are giving, but still the patient is not improving, now we have the biologics targeted against eosinophils like mepolizumab and rallisumab. So you'd take eosinophil count as a surrogate marker. That's all.
The spacers are very
And another issue you asked me about the dose of steroids. See, dose of steroids you have to titrate depending upon the response to treatment. Generally speaking, you may have to give in a day 1 milligram per kilogram body weight of prednisolone or 0.8 milligram of methyl prednisolone you have to give, but it depends how long also it depends response to the dictum is shortest systemic steroids shortest possible time.
Sir, there is a comment there. Spacers are very expensive, more than 550. Many refuse or are reluctant to buy one. We must definitely encourage, because there are lot of subsidized medical stores. For example, Trivandrum SAT Nedi medical store, it's available roughly around 250 or 300 rupees. And I think, and this is not for one time, right? This is for a long time, sir.
Absolutely.
How long can it be used?
Usually 2 years, actually. 2 years. And I would like to add one more point in that. See, you can buy inhalers, and if you are not buying spacer, means you are simply putting it into the 90% your drug is wasted. You are not getting the proper medication, even if you take inhalers. And another point I want to tell you is that many companies, some companies are providing inhalers, spacers free of cost, along with the MDA. So that can also be used.
Sir, there is one sub question there. Like, when you use metered dose inhalers, there is a red mark showing less than 40. Can the patients use even in that moment till it does not give any puff at all?
No. That is what I told. That is why I told. I have told about the tail of effect. See, any inhaler, MDA, it will come 500, 600, 700. It will come. See, in the one, it is marked 120. You use only 120. If it is 150, use only 150. So now red mark is there. You can look 40, 20, 10 like that. So it reaches the bot. It is better to avoid. You will get a aerosol plume that does not contain any medication.
So till what point?
Pardon?
Till what point?
Some companies provide actual number up to 0, 1, 2 like that. Some companies give only the rough actually. So I think maybe less than 10 you have, when it is come to less than 10, you better avoid.
Yes. Sir, another question is during could you please categorize various forms of inhalers? Maybe rotahaler, that.
Yeah, inhalers. So you can classify it into MDIs, metered dose inhalers, breath actuated inhalers, dry powder inhalers. And if you look into the devices, you can have hundreds of devices are there. By company name, rotahaler, loopyhaler, like so many things. But MDA with the spacer is one category. Breath actuated inhalers are other category. Then there is dry powder inhalers are there, and then spacers are add-on. Spacers per se do not have any medication. They are simply a device which serve as a carrier.
Sir, then what does long-term use of inhaled corticosteroids, will it cause diabetes? How does fish therapy work?
Fish therapy, I don't have any idea. I'm not an expert to say that. Fish therapy, I don't know. Sorry. Then long-term use. See, in the recommended doses, I cannot say no. If you are using 1 lakh people using inhale corticosteroids, so no one is going to develop diabetes in the future. But in the recommended doses, not in exceeding the recommended dose, the systemic absorption is negligible and the chance of diabetes are less when compared to inadvertent use of inhalers. But remember, these steroids in large doses have some systemic absorption, and naturally the side effects related to steroids.
Sir, then, okay, we understand the messages like most of the patients coming to government OPD come with ₹70 in hand. Probably my answer as a social health activist is to have some CSR contacts, and let us also, encourage people who can afford to contribute, support bronchial asthma programs in your clinic. I think we can engage some social organizations, and we can very well manage those things. Thanks a lot for throwing light on that, sir. Before one more question, like when we use inhaled corticosteroids, especially in immunocompromised people like diabetes, cancer patients on chemotherapy and all, will it increase the possibility of candidiasis, especially esophageal candidiasis?
See, this is a double-edged sword actually. You have to control asthma first of all, and you have to control the other part also. So the recommendation is there to again in the recommended dose, and you wash. Even though many international agencies do not recommend it now, you have to wash your mouth or rinse properly. That is the only way out. But still, with this kind of immune suppression, there may have esophageal candidates. If it occurs, you have to treat. That's the only way out. Because anyway, we have to correct asthma.
Sir, shall I ask my personal doubt?
Yeah.
I have seen patients, just washing the mouth and swallowing, and then washing the mouth and spitting out. My question is that washing the mouth and swallowing, especially the elderly people might do it. Will it lead to likely chance of, especially in immunocompromised, chance of esophageal candidiasis? I'm not sure.
I didn't experience such things, but that is an important observation. Actually, we have to ask the patient to rinse your mouth and spit out rather than swallow.
Yes, sir. Thank you. How to differentiate between occupational asthma from non-occupational asthma clinically, and specific treatment and specific diagnostic test? Any comments, sir?
That is a very good question, and we have conducted so much research, especially care workers asthma in Alappuzha earlier. See, around 10 to 15% of the asthma is contributed by occupational circumstances. And it is very difficult to differentiate as occupational asthma, work-related asthma, etc., etc. And the only way you can do is that, see, symptoms during your workspace, and when you are taking off, you are free from these symptoms. You can think in terms of occupational asthma. And the treatment is also the removal of the offending agent is the primary modality of treatment. But otherwise, the treatment part is more or less same. You have to use inhaled corticosteroids.
Sir, is the regular use of face mask advisable for asthma patients to prevent asthma exacerbation?
No, there is no need actually. No need. In the general, only when there is a viral epidemic or the government of the health agencies advise. Otherwise, no need to keep. See, asthma is not a stigma. Suppose you use a particular group is using mask and all these things. They get only socially stigmatized. That's all. It is not recommended actually.
Sir, one interesting question in my personal chat box: dandruff and asthma. Have you seen in your clinical experience that dandruff precipitating bronchial asthma? There are
dandruff because of there can be so much dust when you just like the dandruff and you can inhale that. Otherwise, I don't have any experience.
Yes, sir. So thanks a lot, sir. And probably, dear, viewers, probably if you have gone through the chat box, you might have wondered seeing a TCMC registration of 3,000 in our chat box. That is, one of the senior most general practitioners of Kerala, Dr. T.V.P. Surendran sir from Calcutta. I think Surendran sir just left the meeting. Surendran sir is an icon of general practitioner in Calcutta. We met a week back at Calicut in one of the panel discussion. It is truly inspiring that Dr. T.P.V. Surendran, Leo Hospital, Calcutta, Wayanad has attended this program, which indicates that, friends, many people think that we have nothing more to learn. He's a person who has started, general practice in 1960 period, and then now practicing, and then he's coming and listening for a talk of IMA CGP. And plus, friends, I missed his presence towards the end of the program.
I'm blessed by his presence. Not only his senior most professor, Dr. Jayaprakash is also here,
Yes,
hearing. So
and he has said, Jayaprakash sir said truly from the bottom of heart, he also learned something new. See, so if there are people, any person thinking that we know everything, these are the two great gentlemen reply. Their presence and reply matters a lot. Let us learn more and let us be together in every Thursday 8 p.m. Make this venture more useful for yourself and the doctor. And friends, next week, we are going to have the very important topic, should I say, when I started this mission, one of the senior doctor, we were together walking in a meeting, and then I said, sir, do you have any problem? Oh, I only have hypertension. Then I asked, who is treating your hypertension? Oh, a great Padma Shri sir who has stopped practicing 10 years before. That was his doctor. Then I asked him, when did you, met your doctor for hypertension in the last time? Okay. And then he said, Prashant, I met him 15 years before. He has not consulted a doctor, and very respectable person. I'm telling you very frankly that, actually most of us self-treat. Managing self is not a problem, but managing things professionally is a big, if we don't do it, it is a big problem. So let us, at least get updated and revise our strategy. And I made him attend a new physician and check his BP, revise his medication, and probably because that is very important. Such a great person, but still ignoring personal health. And next week, we are going to discuss hypertension. That is why I remember that incident. Hypertension, essential facts on hypertension, how to detect, how to manage, and that is being presented by Dr. Tiny Nair, Head of Department of Cardiology, PRS Hospital. Friends, let us keep our hands together to, give a loud round of applause to the great teacher, and I would say a great human being. Why everyone should become a human being first and then a doctor. He is both. Our PS Shahjahan sir, very personal, friend of mine and a very big brother of mine. Thank you very much, Shahjahan sir. Keep glowing, keep moving forward. Your words of wisdom, your teaching, you are truly an inspiring icon. Thank you, sir.
thank you.
Friends, it's time. So we'll close the program for today. See you all in the next Thursday with the same topic on hypertension. I thank the presence of Dr. Krishna Kumar, the upcoming director of CGP Studies, sir from Alappuzha. Your presence, thank you, sir. And thank you everyone who has contributed for this program. Thank you very much.
Thank you once again. Good night.
O P